Welcome. My name is Giacomo Grasselli from Milan, and we want to discuss the issue of nosocomial infection in critically ill COVID-19 patients. So these are my conflicts of interest. So we know that patients with COVID-19 are at high risk for developing nosocomial hospital-acquired infections. First of all, as we know, the median age of the patients is quite advanced, like 62, 63 in our studies. The vast majority of the patient has comorbidities, in particular cardiovascular comorbidities, diabetes, and COPD. We know that COVID-19 patients frequently need prolonged invasive mechanical ventilation and prolonged ICU stay. They frequently develop acute kidney injury with need of renal replacement therapy. We also know that SARS-CoV-2 infection is associated with immune suppression, and we know that many patients have been treated with drugs acting on the immune system. So all these factors together contribute to increase the risk of infectious complications in these difficult patients. And there are several very nice reviews. This is one of those, showing that the progression of the disease is in the progression of the disease, it's implicated an activation of the immune system and the immune response of the patient, and that these patients have in some way an immune compromise, and this is certainly a major risk factor for the development of infections. In the literature, the data on incidence, frequency, and etiology of nosocomial infection in COVID-19 patients are quite scarce. So I will review only a couple of papers. This one is an analysis of 920 cases from China, from Wuhan, and this was a single center retrospective study. The population of patients is mixed, so it's not only critical patients, but it's also severe patients. And in those patients, the rate of hospital-acquired infection was quite low, 7%. And they basically described 65 episodes of hospital-acquired infections. And on the left-hand side of the slide, you can see the sites and the causative agents of these infections. And in this study, hospital-acquired infections were associated with a higher mortality rate in COVID-19 patients. And this other study from Genoa, from Italy, was performed in 78 critically ill, all critically ill patients admitted to ICU in Genoa, and it specifically analyzes the issue of bloodstream infections, and they observed a quite high incidence of bloodstream infections in COVID-19 patients. As you can see, the incidence was 47 per 1,000 patient days in ICU, and in this study, treatment with tocilizumab, an anti-IL-6 drug, and steroids was associated with increased risk. And the last paper I want to show you is this article published in Clinical Infectious Disease that reviews basically all the studies addressing the issue of co-infections, bacterial and fungal co-infections in individuals with coronavirus infection. So it's not only focused on COVID-19, but it includes also patients with SARS and MERS. And in the end, they reviewed 18 studies. 9 of them were focused on COVID-19 patients, almost 800 patients. And again, the incidence of bacterial co-infection was quite low, around 7 to 8%. But despite these, they describe a wide use of broad-spectrum antibiotics in COVID-19 patients. So in the second part of this presentation, I want to show you the results of our of a retrospective cohort study, multi-center study that was conducted in 36 intensive care units from 8 Italian hub hospitals. And these data are novel. I mean, the paper has just been submitted for publication, so it's non-published data. we included only severe adult patients, critically ill, so admitted to ICU, from February 20 to May 20, with quite a long follow-up. As you can see, the follow-up ended on July 23. The outcomes were the incidence, microbial etiology, resistance pattern, risk factors, and impact on outcomes of hospital-acquired infections. We analyzed only positive cultures that were reviewed by a dedicated intensivist and a dedicated infectious disease specialist in each unit, in each hospital. And infections were defined according to the guidelines and according to predefined clear criteria. And we performed a univariate and multivariate cost proportional risk and competing risk regression analysis. So it's probably the largest study performed so far on this issue. As you can see, we included more than 800 patients. Of these, 9 were excluded. So in the end, we included in the study 774 patients. And almost half of these patients developed at least one nosocomial infection episode. So 47% of the patients had experienced an infectious complication, and the incidence of hospital-acquired infection was 38.5 infectious episodes per 1,000 patient days. This is the cumulative probability of infection, and as you can see, 14 days after ICU admission, the probability of being infection-free was quite low. So most of the patients, the majority of the patients, developed an infection after 14 days from ICU admission. And I will show you now the risk factors associated with the increased risk of infection at the univariate analysis. So among the demographics and patient characteristics, as you can see, age was associated with high risk of infection, the comorbidity index, and the SOFA score, while the single comorbidities like hypertension, diabetes were not. With regard to the ventilation settings, in the population, the median PF ratio was 123, so a moderate degree of severity of hypoxemia. Tidal volume was protective, as was plateau pressure. The median value was 24 centimeter of water, and the median value of PEEP applied was 12 centimeter of water. What the vast majority of the patients were receiving invasive mechanical ventilation, so they were intubated in the ICU, and we didn't see any effect of the ventilatory settings on the risk of nosocomial infections. In our population, the most common infection was ventilator-associated pneumonia, which accounted for half of the infectious episode, followed by bloodstream infection and catheter-related bloodstream infections. Ventilator-associated pneumonia was due in 64% of the cases to gram-negative agents, while for bloodstream infections, the majority was caused by gram-positive bacteria. And what was very interesting and notable in our case series was that hospital-acquired infections were due to multi-drug resistant germs in 38% of the cases, and while the incidence of fungal disease was quite low, as low was viral reactivation. This is the timing of hospital-acquired infection. As you can see, the first hospital-acquired infection occurred after a median of 12 days from hospital admission and of 8 days from ICU admission and 7 days from intubation, while there was no difference in the onset, in the timing of onset of among the different sites of infections. And as you can see in the left-hand side of the slide, you can see the timing of infections for fungal, gram-positive, and gram-negative germs. And as you can see, gram-negative appeared relatively later during the course of the ICU stay. Again, at the univariate analysis, some biochemistry, some lab tests were associated with increased risk of infection, in particular higher neutrophil count, while not the lymphocyte count, higher D dimers, higher creatinine values, and higher ferritin values. And also treatment prior to infection with steroids and the anti-IL-1 agent anakinra were associated with increased risk of infection, while lopinavir/ritonavir was associated with reduced risk, and we observed no association with tocilizumab, hydroxychloroquine, and the remdesivir. And finally, these are the risk factors associated with the probability of developing an infection at the multivariate analysis. And as you can see, only SOFA score, pH at admission, treatment with anakinra, and treatment with steroids were associated with an increased risk. With regards to mortality, the overall in-hospital mortality was 33%, and the factors independently associated with death were age, steroids, and in this case, we observed differently from the recovery trial, an increased risk of death in patients treated with steroids, SOFA score, and infections. Infectious complication had a small but significant impact on mortality and had a major impact on the duration of invasive mechanical ventilation, ICU, and hospital length of stay. So in conclusion, we can say that COVID-19 patients are at high risk for infectious complication. A significant proportion of infectious complication in these patients is due to MDR bacteria, at least in Italy. Nosocomial infections are associated with worse clinical outcomes, and clearly it's extremely important that we implement appropriate protocols for the prevention, early detection, and treatment of infectious complications in COVID-19 patients. Thank you very much for the attention.